challenges that we often have when we talk about mental illness within that community. I mean, I speak from a Muslim community.
For many years we've been working in primarily Wandsworth and also across southwest London, and we were very keen about seeking to develop and adapt the methods which we've learnt over several years in Wandsworth in the neighbouring borough of Merton, and to see whether we can add value to the public services and communities in Merton, similar to the type of work which we're doing in Wandsworth.
So big challenges that we're all facing. Really interesting time in terms of demographic change.
And I came here today because it's really, really important that we involve people from BME communities in decision making around mental health services. And I think today's been a very good start for that process.
Well, having said that, when Malik was up, he talked about the structure that was kind of in place. He talked about a system rather than like a hierarchy thing. What did you think about that idea that he presented?
Well, I think the key thing is that people don't feel that what they see when they see the trust is a mountain. What they see is a local foothill, and they know exactly what the path is to that foothill, and that they feel that they can shape that foothill.
What can we do working with local communities so we can help identify that mental health, that mental well-being at an earlier stage?
I don't think there's blanket solutions. I don't think the solutions are the same for different communities. So I think the first place is to have the conversations whereby we can understand the needs from those communities' perspectives, contextualize the professional skills that we might bring along to help those communities identify, support and treat mental health and promote mental well-being.
Well, of course, one of the big issues is to understand cultural barriers, how to provide mental health services for everyone. And I think it is about dialogue, it's about communicating with each other, it's about working with each other. And I think one of the big messages, if you like, from the speakers was that we really need to understand each other and try to talk to each other before we improve any kind of service provision at the moment. Yeah.
But we also know that people with mental health problems are also victimised in our society. So it's quite a tricky relationship and a quite tricky intersection. And so I start from the premise is that if we're going to work with black and minority ethnic people in mental health services, we need to grasp this.
I think what I said earlier is the lessons that there are out in groups like this is not being taken seriously or not being taken on board by mainstream services, and therefore we struggle all the time and we say the same story all the time and it's not changing. But I'm hoping that this co-production model will teach us something and may move us a little bit further on.
What is the issue with it not being taken seriously when there's so many events like this to say it is a serious problem? And also people are looking for solutions, but we find them here, but why is it not serious?
I think it's because in the mainstream people think what they're offering is the right thing. And until they learn that that's not working, it hasn't made any difference, it hasn't made any change. I think that's, that mindset needs to change.
Well, of course, I act as a service to improve psychological care for people. So what it is doing positively is cutting waiting lists, and it allows practitioners to go out into the community more. So I think that's something that is working. I can only speak for myself, and being flexible in my approach and continuing with training in order to support different communities is something that's really worked for me.
The workshop I was in was looking specifically at improving access to psychological therapies, and there was a range of people in the group, and we had lots of people who have experience of working in the voluntary sector as well as within the NHS. The suggestions were that we need to really think about the barriers to access to psychological therapies. Sometimes it can be as basic as language. If people can't speak the language and you don't have workers who speak their language, how are you going to offer them therapy? We may have to think about people's understanding of what therapy is, and also there are individuals for whom therapy is maybe the lesser of the situations that they're in, and they may have situations that are a bit more basic. They can't eat, they've got no money, they've got nowhere to live. You can't ask someone to look at counselling and therapy if they haven't met their basic needs.
Absolutely, as I said when I was speaking, when we went to the Tamil community, we came and tried to prescribe a solution which plainly wasn't going to work. We then had an open, honest, equal conversation which involved training up members of the local community, which involved us providing some of the services within the temple. And in the end, I think it was a culturally sensitive solution that provided treatment in a way that the community could accept it.